It's not like studying even triple negative breast cancer, which is a big disease, but not anything the size of Alzheimer's. The second is we're talking about cognitively impaired patients, which cuts to the heart of economics, because economics is all about how people respond, how agents respond to kind of how do they maximize this thing called utility. But if you have a cognitively challenged patient, what are they going to maximize? Right? Do they even, it's not just that they might kind of solve the derivative or the integral incorrectly. They might just not know what it is. And so in that world, what is the quality of choice exhibited by these patients, which then raises a bunch of questions around what is the role for government and regulation? Because usually if people can't make choices, then economists want to start to think about welfare improving interventions. Not just government, it could be very long-term contracts. So there's a burden of disease, which I think draws a lot of us, the decision-making and the quality of decision-making by cognitively impaired patients. This is going to be a big part of where economists can add value. So economists often start with sort of the standard neoclassical model, which we kind of start with. It's not the model we actually believe. I think over time, we've refined that model considerably to account for a range of behavioral biases that consumers, patients might exhibit. But what we don't really know is whether a behavioral bias is the same as decision-making by cognitively impaired patients. It might be completely different. Like even when we're talking about behavioral bias, like preferences being time inconsistent. So my preferences today are different than my preferences tomorrow. That might be a behavioral bias, but a cognitively impaired patient might have a much richer set of behaviors being exhibited. And that's something that we're good at studying. The other thing we're very good at studying is how do you think about dynamic contracts? So a contract signed today about some outcome in the future. It might be a contract that I sign in my 40s for long-term care. It might be a contract that I implicitly sign with my children to take care of me. But once I'm cognitively impaired, how do I enforce that contract? How is the contract, or do I need some sort of legal mechanism or regulatory mechanism to enforce that contract? And I think these dynamic contracts will exist between me and my insurer, not just a private insurer, but a government insurer, me and my caregivers. Again, some of them could be private, some of them could be my family. And then finally, one thing that we realized as we started to work on this paper, where economists have a lot of value to add, is about the incentives for innovation, which I think don't get enough attention in this space. If I were a benevolent social planner, then much more than thinking about long-term care and dynamic enforceability of contracts, I would be thinking about what do I need to do to eliminate this disease if I were the dynamic social planner. No individual patient might think like that because an individual patient might not have the time horizon to see this disease being eliminated. It might take this disease 300 years of R&D to be fully eliminated or understood. So no individual person or no individual payer or employer thinks like that. But a benevolent social planner, right, presumably Congress or whoever we think of as the benevolent social planner, ought to be thinking about, do we have the right incentives in place to get transformational drugs for this condition? And economists have done a ton of work on the incentives for innovation and how they ought to be structured. Is 20 years of patent life adequate? Do you need 5 years of exclusivity? Do you need 7 years of exclusivity because of the Orphan Drug Act? Is exclusivity and patents, are they superior or inferior to R&D tax credits for innovation? How do we think about what the Orphan Drug Act does for innovation and what kinds of drugs it induces? Should we only be thinking about pull incentives for innovation, like high prices, or should we also be thinking about push incentives for innovation, like the NIH? So the more you de-risk science, the better the basic science insights, the easier it becomes for investors, for capital markets to come in and build companies around those basic science insights. So those are completely, these push incentives are completely different than the pull incentives you get from patents and exclusivity. How do we think about the adequacy of pull and push incentives in this space? And so if you kind of think about these topics, all of which are very core to economics, right? Burden of disease, core to economics, not because economists are good at measuring burden of disease, but we're very good at measuring the long-term budget situation confronting the United States government, right? So that burden of disease linked to the US budget is one that economists can make extremely well. So that's kind of that's what drew us to this. So I'm not going to tell you about Alzheimer's unless some of you want to kind of learn about Alzheimer's. In our early days, we spent a lot of time talking to clinicians about Alzheimer's as we were writing this chapter. And one insight we got from the clinicians was, listen, they said, you know, there's like two definitions of Alzheimer's. There's the biological the clinical definition of Alzheimer's, which is all about sort of like cognitive decline, right? And then there's the what is going on inside the brain definition of Alzheimer's. And they were like, I as an economist always felt like we wanted the biological definition. And they were like, no, who cares? Like that's a question for us as clinicians, that's a question for us as scientists. You guys as social scientists should just run with this very broad definition of Alzheimer's called, you know, basically just think of it as dementia. And yeah, you'll pick up a bunch of non-Alzheimer's related dementia as part of this, but that's okay. Like to first order, you'll still make a ton of progress on it. So when we say Alzheimer's, we're very much thinking about dementia more than anything else. So should I just stop there in case there's any clarifying questions on what I'm about to share with you? And you can just raise your hand and start talking.
Hi, Amitabh. This is Emmanuel Grable here. Just a quick question. I see that on your list there, you don't mention, for example, some of the implications for labor markets. Is that left out intentionally, or how should the economists think about like some of the human capital, labor market type of issues?
Yeah, that's a really good. I mean, that's a really good question. We talk a little bit about labor markets, Emmanuel. So let me give you the answer we currently have in the draft of the paper, and it's just a draft, so we're constantly adding to it. You know, we spend some time in the paper thinking about Alzheimer's as affecting the labor supply of the caregiver. So that's one place where labor supply certainly is affected. We also think a lot in the paper about life cycle models of savings and asset decumulation, highlighting the effect of medical expenditure risk. That's another place where this shows up. Now, maybe there's like a direct effect of Alzheimer's on my labor supply, right? Which we've not really modeled because we don't think of that as being that different than, you know, sort of taking the normal, how aging affects my labor supply and then tweaking that or accelerating it because of Alzheimer's, which is why I didn't put it on this chart.
Great, thank you.
Yeah, but Emmanuel, you know, again, if I'm missing a literature that's important, you should absolutely tell me, because it's not like we're wedded to an agenda here, right? This is a different paper than what I would normally come and present to you. Normally, I would say, here's a paper on what's the effect of X on Y, and then you would tell me if I had nailed it or not nailed it. And this is not that kind of paper. So if there's a pasture that we've left out that's important, then we are very interested in introducing that pasture to the paper. But I thought what was unique about Alzheimer's was my disease affects my wife's labor supply. And, you know, the caregiving aspects of it are probably not appreciated by economists because that doesn't happen to the same degree with other diseases. It happens some, but it doesn't happen to the same degree. Yeah. So let me just kind of skip all this stuff and say, you know, I think the way we start as economists modeling anything is we will write down the rational model, because that just then it tells us what we need in the model, even though the world might not operate like this. So here's how I've been thinking about it. I've been thinking about it as a very, very simple, this is kind of how I would teach the undergraduates about a problem like this. You know, you've got two states of the world. You have Alzheimer's, which is denoted by S. S is for the sick state of the world, and you've got a working state of the world, or no Alzheimer's state of the world. And what you're trying to do is, as a patient who's rational, you're trying to sort of figure out, what would make you happy. And what makes you happy is your consumption, C, all the stuff you could spend on. Maybe it's your boat, maybe it's Christmas presents, it's a summer vacation, it's stuff. That's what consumption is, right? And it's your health. Those are the two things that kind of matter to you. And what you're worried about is pi. You're worried about some probability that you might be living in a world with Alzheimer's, right? That's what you're worried about. And so immediately what you're going to see out of this is that any kind of technology that reduces the probability of the bad state is going to dramatically improve my utility, right? So if there's a technology, R1, that reduces pi somehow, it could be like primary prevention. We figure out how to prevent Alzheimer's. That is going to have enormous social value right away. Like all the research is about how do I do the long-term care and all that other stuff, and we'll talk about that. But if you were the social planner, right, and you were caring about the well-being of your country today, your population today, but also their children and their children's children, so on and so forth, all of your emphasis would be on pi if you're using a 2% discount rate for the future. It would not be on consumption smoothing. It would be much more, how do I eliminate the disease? That's definitely something that's missing in this literature, is the technology to reduce pi. It could be prevention. I'm not saying it has to be a drug. It could be prevention. What are the incentives in place to discover these R1s? I think the other kind of technology you care a lot about is any kind of technology that improves my health in the bad state. So now I've had the bad state, so I'm not changing pi, but what I'm doing is I'm improving health in the bad state, which is H superscript S. That's health in the state that I'm sick. And that would be kind of, I think of that as secondary prevention, right? Like you already have the disease. Now we're trying to make it a little bit better. Maybe we're making the disease a little bit easier to manage. Maybe we're giving you better long-term care for that disease. We're having someone come in and help you with your financial problems. Maybe we've got a self-driving car. All of these things would be things that essentially improve the cost, reduce the cost of living with the disease. And I think there's a third kind of technology, which is just the consumption smoothing, right? I want to improve financial well-being for patients. So I want to kind of smooth consumption between the good state of the world and the bad state of the world. People hate risk. So they don't want to be in a world where they have all this money to spend if they're healthy. And all these things would give them joy when they're healthy, but then when they're sick, it all collapses down to H of S. Like that would be kind of a bad thing. And so you want some kind of insurance product that allows me to consumption smooth between these two states of the world. So for those of you who are not economists, I will apologize for the next equation, but it'll make sense in just a second. If you believe everything I've said, right? If you believe everything I've said, if you think that at its core, this is the problem, then what you need to do is you need to solve for the optimal level of R1 technologies, R2 technologies. You need to solve for the optimal level of consumption and the optimal level of quality. But there are constraints on people. In particular, the constraint on people is the price of these technologies. These technologies aren't free. So if you had a technology that reduced the probability of having Alzheimer's, whatever that technology is, it would not be free. Certainly if it was a drug, no pharmaceutical company would sell it for a low amount, as we've recently learned. But what if it was not a drug? What if it was just prevention? Well, discovering it would still take a lot of NIH money, research grants to epidemiologists to discover these kinds of prevention, right? So there's these constraints. And there's no reason to think that an individual agent can solve this complicated choice problem. Even say this choice problem is being solved by the agent at the age of 30. There is no way that an agent at the age of 30 can probably solve. These are really, really hard problems for fully rational agents to solve, So the likelihood that a cognitively compromised agent can solve it is extremely small. But the likelihood that a benevolent social planner could solve it is much, much greater. The social planner needs to be thinking, though, of things that social planners have not thought about. So to solve this question that I have in front of you, It's even hard for the social planner because the social planner still needs to know things that are not really knowable. The social planner needs to know, look at my second to last bullet point. The social planner needs to know how patients trade off consumption and health. How much consumption are people, voters, willing to give up for just a little bit better health? That's not a parameter that is going to be stable in the population. I see Dan Polsky on the call, right? I've never met a health technology that Dan Polsky didn't like. So Dan would be willing to give up a lot of his consumption to get a little bit of health. I like consumption. I don't care about my health that much, but maybe my preferences change. And if my preferences change, we're in a really, really sticky world, because now if preferences can change, it means the utility function is not stable today versus tomorrow. The utility function itself could change. Related to that, there are these ideas around something called the state dependence of utility in economics, which is the marginal utility of having a beautiful car or beautiful house changes when you have Alzheimer's versus when you don't have Alzheimer's, right? The utility of consumption, the utility of going out to eat for the patient could be different when I have Alzheimer's than when I do not. And I don't think that economists are great at thinking about all of these. We have the full kind of arsenal of tools available to us to answer these questions, but we have not, because we're not normally thinking about a world with cognitively challenged patients. In fact, the great worry for me as an economist is that we're taught something in the first month of graduate school. We're taught the conditions under which a well-defined utility function exists. That would be a utility function that maps my happiness level as a function of consumption and health. The conditions for that utility function to exist might be violated in the case of cognitively challenged patients. In particular, for that utility function to exist, I need preferences to be transitive. What does that mean? Transitive preferences are very simple. It means if I like tomato soup more than chicken soup and chicken soup more than mushroom soup, it ought to be the case that I like tomato soup more than mushroom soup. That is a key assumption for a utility function to exist. But if that transitivity is violated, if I have non-transitive preferences, then that utility function U of C of H does not exist. And if it doesn't exist, it's actually not clear what we can bring to this problem as economists. So I think it's an opportunity for us to understand the edge case of our discipline and then suggest ways for, other ways to go about maximizing social welfare if individual utility functions do not exist, right? And that's a very hard area of research for economists. So what I'm going to spend my time today talking about is, the paper is really about how you think about these different types of technologies. How do you induce R1 technologies, R2 technologies? How do you induce consumption smoothing technologies like long-term care? That's what the paper is about. I won't be able to cover the entire paper, so I thought I would just focus on R1 technologies. Right? Like how do we think as researchers about whether the world has adequate incentives in place to induce these technologies that might reduce the likelihood of living in the bad state of the world? And a simple way to do that is basically, let me just kind of skip down here to what's happening with Alzheimer's drug development. And if you have questions, just raise your hand and I will.
Amitabh, can I just ask one question? Also, welcome. I'm babysitting and listening at the same time, so forgive my split attention. But my question is, in terms of this utility function, sometimes the person in cognitive decline is not the one making the decisions; it's their caregiver.
Yeah.
And how that might factor in here. There could be like a conflict of interest as well for that caregiver trying to do what's in the best interest of their loved one. In addition to thinking about themselves. And so it just, quickly becomes complicated. I don't know how much you've thought through that piece.
Oh my gosh, absolutely. And so this is very much a model. What we have here is, I think your question is exactly right, Dan. I agree with everything you're asking. This is a model of a single person making a choice. And then you could make it richer and say, well, this is really the model for the family. But the one thing we know about family decision-making is that the unitary model of decision-making is false. Families don't act as though they have a single utility function there's some Nash bargaining that's happening within the household at all times. So even though I might have a stable utility function, even in the presence of Alzheimer's, it's not clear that my son, who's now 5 months old, but hopefully by Alzheimer's, he's a little bit older, it's not clear that he will internalize my utility function. He might take my utility function and add some delta to it, reflecting his own preferences. And so at the heart of Alzheimer's care is not just what long-term care does the government provide, but how well can patients intertemporally nudge their caregivers to maximize their utility as opposed to the caregiver's utility. It's like a version of the principal agent problem, right? The principal is the patient, the agent is the caregiver. And I think that's a question that economists have a ton to say about, the principal agent problem and how you kind of get around the principal agent problem. What we have nothing to say about, though, is in a principal agent problem, normally you're thinking about a CEO who is like maximizing the well-being of shareholders versus buying a private jet for themselves, which is one reason we tie CEO compensation to increases in share price. Now, in this case, that's going to be very hard to do because the Alzheimer's patient, the principal, can't really enforce the contract, right? Because they have Alzheimer's. So the dynamic enforceability of this contract is particularly challenging, right? Relative to the usual principal agent problems that we've been thinking about as economists.
I wonder,
yeah.
Sorry.
No, go ahead, Matt.
Yeah, I wonder if it's less similar to the CEO principal agent problem and more similar to like the physician maximization that we've seen, right? Where you're trying to balance some altruism with your own profit making in a caregiver situation. It's not necessarily profit making, maybe your own time. Those enforceability problems remain, but it might, it's maybe closer to what's going on here.
And in the physician example, Matt, that's such a great point. Some people think, oh, well, if you just unleash the market, you solve this principal agent problem. We've not really seen evidence of that, right? Like there's clearly massive and persistent asymmetric information between patients and doctors. If you have me back to present again, I'll show you some new research we're doing. In Medicare, we've received authorization to find former physicians in Medicare. So we can see how former physicians are being treated in Medicare. And it turns out they're not treated that differently than non-physicians. In particular, our control group is lawyers. So, cardiologists having oncology conditions don't get treated differently, but oncologists having oncology conditions are treated differently than cardiologists or non-doctors. So I think this point about asymmetric information and enforceability of kind of using market forces to improve welfare has not worked out terribly well in healthcare. I wish it did. Our lives would be so much easier. At the same time, it's not like regulation has either figured this out either. Like if you think about half the guidelines that are out there, most of them are just not very good. So using guidelines to discipline providers has also not been proven. So then we are trying to tinker with the prices. We don't really know how to do that. So it's a mess. And my guess, Alzheimer's takes the mess that we're in and puts it on steroids in some sense, right? And I think economists would have a lot to say about sort of understanding the edge cases as opposed to simply saying more regulation would help here, right? Because to your point, it doesn't work in simpler settings as well as we would think. So I'm going to talk about the innovation piece of this. And I just wanted to say that, two things. I mean, this again is known to all of you who are clinicians. This is usually like, I think, surprising for economist audiences. I want to make 2 points up here. One is in the upper left, you see kind of what we're doing, in phase 1, phase 2, phase 3 trials. There is this kind of false thinking, I think, amongst people who don't study Alzheimer's, that all of the research that's happening is focused on the amyloid hypothesis, which is in red. And while a chunk of it is focused on amyloid, not all of it is focused on amyloid at all. At least the Boston VCs don't really seem to be investing that much in the amyloid hypothesis as much as kind of other mechanisms. We don't know which one of these ideas will prove to be influential. I'm speaking now, not in what I'm about to say, I'm not speaking as an economist. I'm just speaking as a future patient, probably, of Alzheimer's. I don't really want a symptom reducing drug. I mean, that might be fine, but like I care much more about some kind of disease modifying therapy. And while the upper left still looks like a big amount of innovation, you might say, whoa, that's a lot of drugs and a lot of ideas. It's actually very small relative to oncology. So if you look at, if you look at the pipeline of where we're doing research and what we're studying, if you look at the preclinical research and the phase 1 studies, half of the R&D we're doing is all oncology, right? All of neurology is small relative to oncology. It's big relative to some other conditions, but it's actually small. Not all of neurology is Alzheimer's. So if you look at like as a share of all the R&D dollars out there, so R&D spending in the United States, private R&D spending across all disease areas is about 130, 150 billion dollars, depending on who you talk to. Lower bound 130, upper bound 150. Alzheimer's is small. It's getting a very small chunk of that 130 to 150. And then if you add to it what the NIH is doing, my sense, you guys would know more, the NIH is spending about $2 billion a year on Alzheimer's. So maybe we're spending somewhere around, maybe we're spending around 13, 14, 15 billion dollars a year on Alzheimer's. But again, from the point of view of the social planner who's trying to reduce pie, you're not going to be able to reduce pie with $15 billion worth of spending. I mean, you need to really figure out a way to make that. You don't get much of $15 billion in healthcare. You just don't. So you have to figure out how to make that 15 billion for Alzheimer's 150 billion, 200 billion, and you have to figure out what other kinds of incentives you need to be able to do that well. I think one of the things that really discourages VCs from going into Alzheimer's, I think there's two things that discourage VCs a lot. But one of them is just the fact that again, this is known to you, failure in Alzheimer's is just incredibly high. So these are the overall success rates for Hep C treatments, the not so good Alzheimer's drugs we have, right? We don't have good drugs for Alzheimer's. The overall success rate is 0.5%. What does that mean? For every 200 ideas entering drug discovery, so above preclinical, only one would be successful. And I'm not defining success as it was a great drug. I'm defining success as the FDA approved it. So if you're a forward-thinking venture capitalist and you got your MBA at Harvard Business School, the one thing I would have taught you probably is you need to look at discounted net present value, expected discounted net present value, but the expected is tiny because the probability of getting the prize is 1 in 200, right? So that's going to just discourage a ton of research in Alzheimer's. And what is unfortunate about the Alzheimer's space is the incentives to do Alzheimer's drug discovery are the same as the incentives to do any other kind of drug discovery, meaning you get 20 years of patent life, and you would get 5 years of exclusivity by the FDA if your drug was approved. But I would get 20 years of patent life and or 5 years of exclusivity if I invented a drug for gout or another eczema drug. And I don't mean to minimize gout and eczema, but relative to where we started, the social burden, it just cannot be the case that we should be offering this disease the same incentives as we offer manufacturers for all the other diseases. Now, we don't know how to reform the patent system. It's impossible to change patents. Patents go back to the first Congress of 1790, which set up the patents as being a 20-year protection from generics. We're not going to be able to change. We don't even know how to change that to like more patent life for Alzheimer's drugs. So we can't start there. We have to start at the level of the FDA. Congress has to permit the FDA to offer longer exclusivity periods for transformational Alzheimer's drugs. I don't think Congress can be put in charge of this. Congress will not know how to do this. But I think Congress could give the FDA the authority to do something like this. I don't know if the FDA wants that authority, but they certainly have been given, we give extra exclusivity for orphan drugs, right? We give extra than for non-orphan drugs. So I think that kind of thinking could certainly be applied to Alzheimer's drugs. So that's kind of one thing that we have to be able to do. The second thing that we've got to be comfortable with, and I realize I'm about to get into a lot of trouble here in the seminar, is One way around this very high failure rate and the very long nature of Alzheimer's trials tend to be long because we're trying to show we change the course of the disease. So the trial, might take 2, 3, 4 years, is we're going to have to develop validated surrogate endpoints for Alzheimer's. I'm not a scientist, so I don't know if beta amyloid is a validated endpoint. It may be unvalidated. It might just be an idea that's out there. But if we could validate, if we had a good surrogate endpoint for Alzheimer's, I don't have to do 3, 4 years of a trial. I can do a 1-year trial. I could do a 6-month trial, which would leave me with more patent life, which would make the likelihood of having a positive expected NPV project go up, which in turn would induce a lot more capital to come in. So if we're interested in kind of getting private capital to come in, we're going to have to think about A, longer exclusivity periods, B, greater use of surrogate endpoints. And I think the FDA is uniquely positioned to figure out what those validated endpoints are likely to be. 2 other thoughts on this. One is just, I think, a thought that people forget, which is the size of, I'm talking again about these pull incentives for innovation, the extent to which firms are responding to the promise of profits. One very simple proxy for that, it's not perfect, but simple proxy for that is the size of the prescription drug market across different countries. So worldwide, we spend $1.2 trillion on drugs, and that market is growing at about 5% a year. The US market across all drugs is about $485 billion. Let's round that up to $5 billion. So we spent $500 billion, on drugs. All the drugs, $500 billion. Just to put that into perspective, Apple's revenues last year were about $300 billion. So total drug spending in the United States is, more than Apple's total revenues, but of the same magnitude as Apple's total revenues. Top 5 countries in Europe, so these would be countries like UK, Germany, France, they're actually very small relative to the US, right? Total drug spending in Europe is about $200 billion, right? And the US was 500 billion. So sorry, not total drug spending, top 5 drug spending in the US. Why am I putting on this all up? I'm saying that the incentives will primarily be American incentives. There's really nothing. This is not a criticism of the Europeans or anything like that, but these are very, very small markets. Europe is a very small market for manufacturers. The pull incentives from Europe will not be enough to induce more innovation in Alzheimer's. The countries that are called pharma emerging, these would be like India, China, Brazil. They're bigger than Europe right now, but they spend principally on generics, right? So they're not really spending on the latest CAR T or the latest immunotherapy. And Japan is actually a very, very big country. Japan is a very serious source of innovation because its drug market alone is about $90 billion, which is a big drug market for such a small country. So I guess it's a long-winded way of saying, if we're talking about increasing exclusivity periods and we're talking about ideas like R&D tax credits, I think the place that needs to move is the US. Maybe we can do this in concert with the EU and all of that, but it's all going to be small relative to the EU. To put an even finer point on it, if you look at kind of the particular size of the drug markets in other countries relative to the US, if you benchmark the US drug market at 100, and you say, what share of the US market is the drug market in other countries, Belgium is 1% the size of the US drug market. Canada is 5% of the US market. The entire Canadian drug market is smaller than the drug market from the state of Texas. So why is that important? It's another way of saying if Texas did something unique, I don't think we would change the shape of Alzheimer's drug innovation, right? So we need to think much bigger than getting the Canadians to do X or Y, because getting the Canadians to do X or Y is the same as getting Texas to do X or Y, and that's not going to move the needle. We're going to have to think, if we're thinking about pull incentives, we're going to have to think much more, what is the US going to do in concert with the Europeans? Because a lot of these other drug markets are just too small individually to change anything. So I've talked a lot, maybe too much, about these pull incentives for innovation. I think they're incredibly powerful. That's one reason that half of the R&D portfolio is oncology, because in oncology, we have great validated surrogate endpoints, and we have a very high willingness to pay as a country. You know, the Medicare and Medicaid, for example, have to cover every FDA-approved oncology drug, which means that the pull incentive for manufacturers is colossal. It's another way of saying we should not ignore the size of the pull incentive. But pull incentives are not the only thing out there. There's also push incentives, right? So can we create better basic science that would make the investor's decision easier? How would that work? If investors are maximizing the expected discount, the expected NPV of a project, one way that I can increase the expected NPV of the project is by making the project less likely to fail. And one way to make the project less likely to fail is to seed the project with better basic science than I'm currently using right now. So the NIH funding for Alzheimer's has been creeping up, but again, relative to the size of this problem, I don't think a social planner would say, I have a problem that costs my society $500 billion a year. That number is only going to increase with time. So it's 500 billion now. It's going to increase with time. So what am I going to do to reduce the likelihood of it increasing? That's, in other words, what am I going to do to reduce pi? I'm going to spend 2.3, 2.5 billion dollars a year. That just does not seem right. It seems like this, the allocated inefficiency here is really first order. I would not, if I was an individual, you know, if I was a banker, professor, citizen, if I was facing $500, you know, a chance of $500, losing $500 with virtual certainty, I would not have an insurance premium of $2.50. I would be willing to spend a lot more in my insurance premium. And I don't think we have seen anything like that happen with Alzheimer's. We do know that the NIH has many problems, but we do know that NIH funding does result in more, in more discovery. So like every $10 million means about 3 more patents, right? Now, we don't really know if it means 3 great patents, 3 breakthrough drugs. We don't know any of those things. But if you think that patents are a surrogate for discovery, for innovation, I think they certainly are a surrogate. This is an incredible deal. For every $10 million you spend, if you can get 3 patents, then why are we spending only $3 billion, right? We should be spending a lot more than $3 billion. So that's kind of another observation that I have. So let me just stop and take some questions. I've got many more slides. So I'm kind of just, I think I'm very early in my talk. Yeah, I think I'm on slide 13 of 20. So I can keep going for a while, but I thought I would stop there and get a discussion going and get some comments from you on what we're missing.
I'll ask something. Just maybe you can comment on the recent, FDA decision in the context of what you just talked about.
Yeah, so here the FDA decision puzzled the heck out of me. It puzzled the heck out of me because it had this advisory panel that ruled, I think, 10-1-0 against approving aducanumab. And so that advisory panel, which I think comprises a lot of good scientists and clinicians, was overruled by the FDA. That surprised me. That said, I don't know, and I don't know the answer to this. I'm speculating here, Dan. Maybe the FDA decided to do something that is not in its charter, but maybe the FDA decided to say, you know what? We really need something great for Alzheimer's. We're going to approve this thing. It's going to be very expensive for society. We get that. Biogen's going to make $50 or $100 billion for a drug that's not very good. So I'm not going to defend the drug. I think the drug is like basically a useless drug. But we're solving the benevolent social planners problem, because what is spending $50 billion a year relative to the additional R&D that this decision might induce? This is not the FDA's job to be doing that, which is why I'm very uncomfortable that the FDA did that. If it did, it might not have done that. It might have had a completely different calculus in its head. But there is an extraordinary timidity to how we approach drug pricing and drug spending in the United States. Like I said, it was, the spending is about $500 billion a year. I don't know. To me, it doesn't strike me as a lot of money. I am not connected with Biogen and the drug companies in any way, and I'm very critical of a lot of the things that they do. $500 billion a year, if you're using any kind of discount rate and putting value on future lives and things like that, doesn't seem like a lot of money to me, right? We clearly are able to spend $300 billion a year on Apple products. So why can't we spend $500 billion on the total basket of drugs? We need to be able to understand the answer to that question. So maybe the FDA went outside its mission and said, we need to approve this drug, not because we think it's a great drug at all, but because we want to send a signal to future manufacturers that, we will, as long as your drug is safe, we'll approve it because knowledge is cumulative. We'll learn something from aducanumab that aducanumab might prove helpful in some combination therapy 20 years from now. I wish I knew the FDA's thinking on this. I don't understand it. My own instinct is not to have approved that drug because I put a lot of weight on the advisory panel. But at the same time, the FDA scientists spend a lot of time thinking about all of these issues. So I'm not convinced that I know better than them. I would like to get their story for why they approved it. And I was trying to offer one sympathetic story for why they may have approved it. Emmanuel.
Yeah, Amitabh, what you presented here looks at pharmaceutical solutions. I wonder if you've given some thought to non-pharmaceutical interventions. When we think about prevention, those type of interventions tend to also be very, very effective. Or at least they are some of the first toolkits that we have compared to pharmaceutical interventions. So what have you given some thought to potential issues like misalignments of incentives, and how can we get pharmaceutical companies to actually go into that turf? And also, how should NIH be spending its funding toward or supporting these type of interventions?
Yeah, that's a great question. So if you just bear with me for 1 second, I'm trying to find my prevention slides. I didn't have them ready for you, but if you just give me 1 second, I want to talk about prevention because we do spend a lot of time talking about prevention in the paper. So let's click out of this, and I think I should be able to pull up some other slides on prevention. Here we go. Work. So I think that we're not thinking enough about preventing this disease. We're thinking much more about these very traditional pull incentives to induce novel therapeutics. And the economist in me has to be very humble about the role of therapeutics in reducing disease. I mean, certainly in the case of cancer and lung cancer in particular, there's no drug that the industry gave us that matched the insight that smoking was bad for your health. That preventive insight saved so many more lives than all the drugs that we have discovered, right? So then the question becomes, do we have the right incentives in place to discover non-pharmaceutical prevention? And I would argue absolutely not, because non-pharmaceutical prevention, the discovery of that insight, is not appropriable by the inventor. So suppose I discovered that getting 9 hours of sleep reduced Alzheimer's causally. Not like what Deepak Chopra says and all that, but like causally I showed if you got 9 hours of sleep, I'm sorry, Dan, you might reduce the likelihood of developing Alzheimer's at the age of 80. Who has the incentives to discover that? You can't get a patent on that. It's not patentable. It's not patentable. No pharmaceutical company would spend 1 second trying to discover that extraordinarily important insight, right? And that's a huge opportunity for government to come in and rectify this market failure, right? So I think if we had better research on sort of what kinds of preventive ideas might causally reduce the risk of dementia. It might be diet, it might be exercise, it might be sunlight, it might be sleeping. Who knows what it is, right? I don't think any company will ever discover that. I think it's going to be someone writing a paper and doing a clinical trial on that preventive insight in JAMA or the New England Journal of Medicine or the BMJ. And I think we severely underinvest in that kind of research. So the NIH budget is what? $25, $30 billion a year. I've got this really depressing graph for you. I'll put it up in a second here. Let me see if I can find it. Here we go. Here's my depressing graph, and I will share my depressing screen now, and you can tell me if you all see it. Do you all see it? NIH funding as a share of GDP. Thanks, Mark. What you can see is like, it's actually been falling since 2005. So people are like, wow, President Obama was a big fan of science. Not in the data, he was not a big fan of science. He was not, all right? So if you look at the shortfall in NIH funding relative to trend, today, relative to the pre-2005 trend, we have an NIH budget of about $60 billion. It is sitting at below $30 billion. So we've lost about $30 billion of NIH funding, which would be the kind of funding, Emmanuel, that would give us, some social epidemiologist somewhere would discover that preventive insight, and a bunch of clinicians and economists would do a clinical trial verifying that preventive insight. We're unlikely to find it with these paltry levels of funding. Again, I think we're starting as a country with the budget problem, which is like, NIH budget, how do we make it smaller because it's solving some future problem? I think that's incredibly, incredibly timid. The NIH has a colossal return to both the therapeutics and to prevention, right? I would put another 0 in that NIH budget. And there might be a ton of waste, I don't care. I just kind of think of it as the benevolent social planner would say, if the NIH gives us good research, 1 in 20 R01s, you get the R01 funded, 1 in 20 R01s does something useful, 19 out of 20 R01s are useless. It's still a pretty good bet. Hey, Mark.
Hi, Amitabh. Thanks for the talk. Can you hear me fine?
Yeah, loud and clear.
So I thought you might have been going, like when you showed the utility framework and then led us to the clinical trial sort of funnel chart, I thought maybe we would be going to the point where like, what is the optimal, what is theoretically the optimal level of funding for Alzheimer's? And I think probably everyone on this call would agree that more funding for Alzheimer's would be good. But I guess, is that something your team is looking to derive? And I guess how do you think that would compare to maybe the mismatch for other diseases? And I'd be interested in sort of like, is it that the NIH is underspending on all important diseases, or is it Alzheimer's that's sort of the outlier here?
Well, here's my slide on that, Mark. I wrote something is wrong. So I clearly agree with the spirit of your question. I think that the pull incentives in oncology are already very strong, that I don't know if we still need further NIH funding. So in other words, the fact that the federal government can't walk away from any FDA-approved oncology drug is going to induce a colossal amount of innovation in its own right, right? So it's not then clear that I need all this other NIH work. Now, I'm okay with it, just to be clear, I'm okay with it. I think we should spend much more on the NIH. But if you said you can't spend more on the NIH, I would be moving a lot more money into heart disease, which is the #1 killer, and Alzheimer's. But Alzheimer's right now is the #6 killer. But from a social welfare point of view, we don't just care about lives lost, we care about, the experience of life lost. It's probably enormous. Absolutely enormous. So I don't understand any of these numbers, right? Like, I'm okay spending $60 billion on cancer. Remember, the denominator here is an economy that produces GDP of $22 trillion, which is a trillion is 1,000 billion, right? How can the right numbers for thinking about basic science and the reduction of pi be of this magnitude? If I put any weight on the future, Mark, any weight on future generations, by future generations, I mean Amitabh Chandra 10 years from now, and his kids and his grandkids, I don't think you'd come up with this number. You'd have many zeros in this. So yeah, so my, the short answer is I think I would spend just more on the NIH, not do the reallocation, and advocate much more for a stronger NIH, because I think with the stronger NIH, you get more capital as well, right? Like as you make the science better, the chance of failure falls. And as the chance of failure falls, expected NPV from a project goes up and the VCs get interested in it. So the NIH would be a great way, pumping up the NIH. You don't want to fiddle with exclusivity periods and surrogate endpoints. It's a great way to do this. I think we have to do that advocacy at the NIH. I don't think the other thing is that the research community, we've probably not done it, right? We've probably not, we kind of, I don't know why we haven't done it, but maybe we've probably not done it. Just writing down that simple model mark, taking the first derivative and showing we're off by 2 zeros might be what we need to do.
So Amitabh, I think we are at the hour. Thank you from all of the Head Center for an amazing, thought-provoking talk. We'll reserve the right to invite you back once we, chew on all you've made us think about here. So just a warm thank you from all of us, and I hope catch you soon at a live conference, not too distant future.
I can't. Speaking of innovation, I'm grateful for my second shot. So the innovation certainly made it to my house. I did want to say a lot of our paper is about long-term care, how you create a market for long-term care, right? Because in the short run, patients don't care about innovation. For me, it's not going to happen in my lifetime. What's going to happen in my lifetime is the consumption smoothing. So I don't want to lose sight of that. I'm just saying, if you were the benevolent social planner, you care less about Amitabh Chandra's problem. You care much more about the discounted stream of utility from all his descendants. And that's what draws us to innovation. But for today's voters, the issues are fundamentally about long-term care. So a lot of our paper is around long-term care. And that's I don't mean to say this is long-term care is not important. It's extremely important, and it's likely to be important for the next 100 years. So thank you again for inviting me.